Yes, we can see the presentation.
Okay, thank you. Thank you everyone for joining us in this presentation on measles. Definitely something timely and what is being experienced throughout the country and throughout the world. I'm basically going to give some information on what is currently going on here in Hawaii, or what we've experienced here in Hawaii, and also trying to give a little bit of information again of what Dr. Seward presented, so that way we can all make sure that the information that was provided to us is kind of reiterated again, and that we make sure that we're all following through. So the first slide, I'm going to kind of give a little bit of an update on what is currently happening right now in the nation. The presentation was last presented in February, and so as of April 3rd, there are currently 159 cases of measles, and that includes 18 states. Of the 159, 117 of those cases are considered to be linked to the Disneyland outbreak, which started in December of 2014. So as you can see, there's definitely a lot of cases that are going on and spreading out throughout the country. Most people were unvaccinated, or that they didn't know their vaccination status, 9 out of 10 individuals, and a minority or small group were vaccinated, 1 out of 10. In addition, there were 10 individuals that acquired measles elsewhere and brought it into the U.S. after getting infected, and then spreading it to other individuals. So the key message here is that in the U.S., we still get importations, and so we always have to keep vigilant with measles throughout the year. In Hawaii, the last outbreak that we had was in 2014, and even prior to this was in 2010, where we had 4 cases on the Big Island, and there were 4 children that were unvaccinated and acquired the disease in the U.S. mainland, and they were actually visiting a lot of the theme parks, and then came back to Hawaii, and then came down with the disease. From that time to 2014, in February, we had an unvaccinated 11-month-old child that traveled to the Philippines, acquired disease, and then brought it back to Hawaii. At that time, and as Dr. Seward mentioned, there was a huge measles outbreak in the Philippines, and it was something that we definitely had some effects that came over to us. And so this particular child came back and was traveling from the Philippines, then to Guam, and then to Hawaii, and was infectious throughout the plane ride. And so we had a lot of work to try to contact and identify individuals in the planes that were in close proximity to this child. That was a lot of work that we had to work in conjunction with CDC to get those individuals identified. As far as we know, no individuals were infected during that time period. But if you do know the investigations on the plane, a lot of the information that people put down are not complete. So we didn't have a lot of phone numbers or working phone numbers, addresses that were current, or email addresses that were current. So a lot of the investigation that my staff did, we were actually at dead end as far as trying to identify individuals. So as far as the individuals that we could identify, none of those people actually came down with disease. This particular child had multiple site visits to a doctor's office and also to the emergency room, and there were many, many contacts identified. And so this particular child exposed or could have exposed a lot of individuals. Luckily, we only had one secondary spread to this particular individual, and so we kind of sort of dodged a big bullet at that time, because like I said, there were 2 physician offices that this child went to and 2 ERs that this individual went to multiple times, and so was infectious and could have easily spread. I'm thinking that majority of the people may have been vaccinated at the time because the child was very sick and was coughing and had runny nose at the time. So again, like I said, we were really lucky in February of last year. Then in October, we had a call into our office about a case, and initially we had 2 importations, one coming from the Philippines to Maui, and at the same time another importation from Bali to Kauai. And in these cases, for the Maui cases, the index case was not vaccinated and then gave it to one individual, 6 months old, and then also infected a healthcare worker. In Kauai, the 3 index initial cases were unvaccinated 18-year-olds and came back and then spread the disease to other individuals, and they actually had 4 other people that were sick from this. And so it was a very interesting case, and we were lucky again that this didn't spread any further than it did. Majority of these cases stayed home, and except for going to the doctor's offices, but majority of the time they were actually in isolation at home. So the spread was minimal. Then on the island of Maui, we had a 3rd importation from California, and this individual went on vacation and then came back and then exhibited disease. And then we then had 2 additional cases on Oahu, and we had a hard time trying to link these individuals and try to find out where they were, if they actually acquired the disease from elsewhere or from the neighbor islands. One of the actual cases on Oahu did go to both Maui and Kauai during the infectious period of individuals on those 2 islands, but we couldn't find a link, direct link to this individual with those other cases, and so it was very difficult. And by the time the investigation went on, it was just harder and harder to try to pinpoint and identify individuals. So in October of 2014, we had a total of 13 confirmed cases, and with these 13 confirmed cases, we actually had over 1,000 identified contacts to these cases. And the reason for that is because of the fact that these individuals went to ERs or to doctors' offices and exposed individuals in those offices. And so we had to identify all these individuals and do contact tracing on all of them. So there's a lot of work involved, not only here for us at the Department of Health, but also for your offices, for the clinics that were involved, because they had to pull up the names of all the individuals, had to identify if they've been vaccinated or not, and assist us throughout the whole process, and then get us contact information so we can call these individuals up and then monitor them throughout the duration of the incubation period, and seeing if they actually came down with disease or not. So a lot of intensive work, not only for the Department of Health, but also for the clinics and or the ERs or hospitals that were involved. So when Dr. Seward was saying that it is a really costly type of effort and work, it truly is. And there's a lot of effort and work by staff to try to minimize the spread of measles and identify individuals that are susceptible to the disease. So on this next portion that I'm going to be going through, I'm actually going to be reiterating a lot of what Dr. Seward presented, just because the slide set didn't progress as we would have liked, and so I wanted to make sure that the information was just repeated again and with emphasis, and I'll be adding a little bit of information as we go along. So again, with suspect measles, a lot of Hawaii healthcare professionals have never seen a case of measles. It's not seen often, and because of that, it's very difficult to diagnose. And a lot of people, especially for the February 2014 case, the common diagnosis was that the individual had a heat rash. And even though the parent the mother told the individual that, or told the physicians that she just came from the Philippines and was in an area where there was measles, it wasn't taken to heart. So that was a very, very difficult case to track, especially when the parent informed the healthcare professionals. And what happens is when there's a delay in diagnosis, it definitely contributes to transmission of disease. And so we want to make sure that that does not occur. So we have to do timely reporting. And as Dr. Seward mentioned, consider measles and differential diagnosis of a febrile rash illness. She mentioned Kawasaki, scarlet fever, dengue, and also chikungunya. And here in Hawaii, one of the cases in Kauai in 2014, they were actually, I take that back, 2 of the cases were being worked up as if they were dengue or chikungunya. And so they didn't even test for measles until the test came back for dengue and chikungunya as negative. And then that's when they tested for measles. And so we were running around like crazy trying to identify individuals. People that have had travel history or exposure to recent travelers, or they've been in areas where measles is spread in their community. That's part of the history taking that you're going to be doing when you're talking to your patients. And so trying to get that type of information is really important. And also really, really important is for people that have been unvaccinated and they're coming down with febrile rash type illnesses. You want to make sure and find out, and do a little bit of workup and suspect that it might be measles. Some of the clinical features, and again, this is just a repeat, it's an acute viral respiratory illness. There's a prodrome, 2 to 4 days, which includes fever as high as 105 degrees Fahrenheit or higher with malaise. And then as was mentioned, the 3 C's, the coughs, coryza, runny nose, and or conjunctivitis, red watery eyes, and Koplik spots when present. We don't often have the ability sometimes to catch the Koplik spots, so it's not always there. And then followed by maculopapular rash. Rash usually appears 14 days after a person is exposed, and then it ranges, the incubation period is usually from 7 to 21 days. And the rash usually spreads from the head, around the hairline, to the trunk, to the lower extremities. And so that's usually the course of spread of the rash throughout the individual. So as far as the response for the Department of Health, and this is for suspect, probable, and confirmed cases, isolation of cases is really, really important. Individuals are infectious 4 days prior to and 4 days after the rash onset. And so we usually determine and we ask the question, when did your rash appear or show up? And then we determine 4 days before that and 4 days after where this individual may have been, who they may have been in contact with. Once you've identified or you suspect that it might be measles, you need to notify us immediately. There's some numbers at the end of the presentation to call and let us know. And so we can be part of the process of trying to help you determine if this is really measles or not and what tests to order. And what happens is then we start here at the Department of Health perform enhanced measles surveillance, trying to look at and see if there's any measles going on nearby or wherever these individuals may have traveled if they did travel. And so there's a lot of things going on, and we're here to help you out. And as the next bullet point points out, contact investigations and response efforts kick in immediately. What we do is we communicate with your office and also the patient. We try to identify all individuals that may have been in contact with this person, and then we start identifying where they may have been, and just finding out their vaccination history information. And so there's a lot of work that goes on, a lot of questions that are going to be asked, and a lot of documentation on our part. The other thing that we always ask also is, especially with the ease of taking pictures and stuff like that, we always ask physician offices if they can take a picture of the rash, or if the patient has already left the office and we're talking to them, we usually ask the parent if it's for a child or the individual themselves, if they can take a picture of the rash and how it looks like. We're trying to document a lot of these rash-type illnesses, and trying to see what it is and what it looks like is really helpful to kind of sort of paint the picture with the other things that are going on with the prodrome, with the cough, conjunctivitis, and coryza, with the fever and everything else, and then also how the rash looks. So trying to get an overall sense of what is going on with the individual is really, really important. And so this is something that we've been asking a lot of people if they can take pictures of the rash, and so we can view it and then assist the clinics on trying to determine if it is measles or not. So part of the measles guidance, again, is that if measles is suspected in a clinic, in an emergency room or hospital setting, we need to definitely isolate immediately. Airborne isolation precautions need to be established. Individuals need to be put in isolation rooms, and or if there's no isolation room, put in a private room and close the door. As was presented earlier, mask the individual, especially if they're coughing and sneezing, because then they're aerosolizing the virus. Ensure that all healthcare personnel have evidence of immunity, and that they are, that it's really important. And so just to talk a little bit about this one here, in your offices, it's really, really important that you determine and find out if your staff are or that they have presumptive evidence of immunity, and to document that and make sure, because that's one of the first questions we're going to ask once an individual has been identified, especially if it's in your clinic or in the emergency room or a hospital setting. The first thing we ask is, of the staff that are working there, how many have been vaccinated or unvaccinated? And then we start working with you on that, and then also trying to identify the patients that have been in contact too. And so there's a lot of work. And so if you have all of this information ahead of time and it's readily accessible, that can be done quickly, and we can identify and put our efforts into trying to contain for those other individuals that don't have the information readily available. And so that's something that's really important in your clinics and if you're in a hospital setting or an ER setting to try to collect that information. In a hospital setting or ER, respiratory precautions also need to be included, and even for those people that do have evidence of immunity, just making sure that you're masked up too. So it's really important to just have the proper precautions in place when examining patient. So for laboratory testing of suspect cases, individuals most likely will come to you because a rash has erupted, and then their body now is all over. They're like, what is going on with my body, and why do I have this rash? And most likely they're coming into you to come and see you so you can determine what's going on. So one of the tests to determine acute illness is serology for IgM. And I know a lot of people kind of sort of get this mixed up, and they end up ordering for IgG. But IgG will not tell you if it's acute. So IgM is really important to determine if it's acute measles. And this particular test here in Hawaii is done off island. So it takes sometimes up to 5 days for results to come back. Sadly, we get some offices that wait until that test result comes back and then let us know, and then we're informed that, oh, by the way, it's positive for IgM. And by that time, 5 days has elapsed, and that already has kind of put us behind in trying to do our contact tracing and investigations and identifying individuals that have been susceptible or may have been susceptible to measles. So as soon as you're testing for and you think or you suspect it, you should be calling up the Department of Health, and at least we can note down that this is what's going on, and we can communicate with you to try again to determine if it really is measles or not, and identify individuals of concern, those that are highly susceptible, pregnant women, children less than 1 year of age that haven't been vaccinated, and or immunocompromised individuals. So again, it's really important. Timeliness is really important. Another test that's offered here in the state is PCR testing at our state lab. But in order for us to test there, again, the Department of Health has to be contacted. We have to work in conjunction with the clinic and to determine if it actually does sound and look like measles. And so once that determination has been made, and a nasopharyngeal swab or a throat swab or a nasal swab will be taken, and once that sample is taken, we then have it sent over to the state lab for PCR testing. Normally, depending on the timing, we usually get the results the day after or 2 days at the most, and that's just dependent on how quickly the samples are taken up to the state lab and processed by the laboratory staff there. Another thing that we also ask usually while blood samples are taken and throat swabs are taken, we usually ask for urine to be taken also for viral isolation and hopefully for genotyping if it is determined to be measles through the PCR test or through the serology testing. And then at the same time also, we also ask for, while you're doing serology for IgM, we ask that you just order for IgG also. And if any of these tests come back as non-specific or equivocal, we usually get another blood sample 2 weeks after to compare for IgG and to see if there's any rise in antibody titers. So as far as the testing is concerned, and for IgG, that one is actually done here on island, and so we can get an IgG result pretty quickly. It's the serology for IgM that takes a couple of days and has to be done off island, and so that's very difficult. For the genotyping, to determine what genotype the actual virus is and where the individuals may have been exposed, that is done at CDC. So once the sample is tested here in Hawaii, that sample then is forwarded and sent to CDC for further analysis, and genotyping will occur. And so that's how we were able to identify not only from where individuals traveled from, but also by genotyping, we were able to identify that particular viruses came from particular regions or areas in the world. And there was a really nice mapping that was shown by Dr. Seward, identifying where genotypes are spread throughout the world. Again, it's really important to report immediately to the health department once you suspect that it's measles. Again, we're here to work with you and to try to provide as much assistance, and at the same time ask all the questions and hopefully make sure that you collect all the proper specimens and are requesting for the appropriate tests for us to identify what disease it is. Another important thing is offering vaccine or immune globulin immediately to household members that don't have evidence of immunity when we're doing the investigation. And so again, timeliness is really, really important for us to be able to do our work and to stop the further spread of this disease. So for contact investigations for individuals that have been exposed to measles, people that have been exposed during the case or the index cases infectious period, the area, most likely enclosed area, includes exposure to the area where the case was present at and up to 2 hours after the case has left. And so a lot of times when we work with clinics and or ERs and hospitals, the first thing we ask is, what time did the individual arrive, who else was present, and then 2 hours after that, give us the individuals that may have been exposed. What we do is we contact these individuals, we let them know that they may have been exposed to a case, and we let them know about the signs and symptoms of the disease, and that we are going to be calling them up to monitor if they come down with any of these symptoms, and if they do come down with symptoms, that they need to contact us immediately, and contact their physician and let their physician know that they have been exposed, so that if they do go into your clinics, that the individuals either come at a time prior to closing so that they're not exposing other individuals, or that they come right into an isolation area so that they're not spreading the disease any further. We need to establish presumptive evidence of immunity for contacts. One important way is to find out their vaccination history, especially if they are clients or patients of yours in your office. A lot of times we will be asking you for the vaccination history for these individuals so that we can determine if they've been vaccinated or unvaccinated. And then also, the important thing is to quarantine contacts who do not have presumptive evidence of immunity up to 21 days after exposure, because the individuals can come down with disease or show disease up to 21 days after exposure to individuals with disease. Also really important is, and as I reiterated or said earlier, the timeliness of letting us know here at the Department of Health is for us to be able to try to provide post-exposure prophylaxis either through vaccine or immune globulin. So this was a slide that was presented in the talk by Dr. Seward, and the presumptive evidence of immunity for measles. Normally, routine vaccinations, or for individuals that we provide, is documentation of age-appropriate vaccination with a live measles-containing vaccine. For preschool-age children, usually the recommendation currently is 1 dose, but for school-age children and those individuals in the universities, the current requirement is 2 doses. And then for any adults not at high risk, currently the recommendation is 1 dose. And outside of vaccination, the next presumptive evidence of immunity is laboratory evidence of immunity, and the third one is laboratory confirmation of disease, and then the fourth one is individuals born before 1957. And then for students that are in post-high school educational institutions, it's a requirement, a state statute here in Hawaii, that they have to show documentation of 2 doses of MMR vaccination and or laboratory evidence of immunity or laboratory confirmation of disease, or if they were born before 1957. For healthcare personnel, it's really important to show documentation with 2 doses of MMR vaccination and or laboratory evidence of immunity, laboratory confirmation of disease, or individuals born before 1957. For those individuals that were born before 1957, a lot of times individuals will have drawn their blood and then the titers are either negative or equivocal. And so it's just a good idea to make sure that individuals are vaccinated. The current, and this is something the ACIP recommendation is listed below on that URL, so you can actually go to that particular URL to look up this information even in more detail. It's pretty, I forget how many pages the document is, but the individuals that if an individual receives 2 doses of documented, spaced appropriately, and given age appropriately, 2 doses of MMR vaccination, that is enough for presumptive evidence of immunity for measles. CDC does not recommend that these individuals get tested for antibody, if they've developed antibody or not. And so as far as healthcare personnel, individuals that have gotten 2 doses of measles-containing vaccine and let's say were tested and were negative, there's currently no recommendation right now from CDC to give a 3rd dose of MMR vaccine. And so the recommendation right now is if you have 2 doses, that is sufficient right now for presumptive evidence of immunity for measles for healthcare personnel. For international travelers, especially in areas where you do know that measles is present, you want to make sure that individuals are given age-appropriate vaccination with live measles containing vaccine. So anybody between, or infants between the ages of 6 to 11 months, 1 dose is recommended, but that particular dose is not counted, that child would have to be revaccinated again when they turn 1 year of age or older. So individuals that are 2 or greater than 1 year of age, 2 doses are recommended, or if they're able to have or show laboratory evidence of immunity or laboratory confirmation of disease, or individuals that are traveling were born before 1957. So for post-exposure prophylaxis for MMR vaccination, it can be administered within 72 hours of exposure. Most individuals may return to normal activities except for healthcare settings. What we do also is we monitor these individuals for signs and symptoms of measles. It can be given down to age 6 months, but that's usually when there's an outbreak, a major outbreak going on, and that we also need to be aware of the possibility of vaccine-induced rash for these individuals that have been vaccinated. So it's really important to make sure that we monitor and identify who these individuals are and keep a close eye up to 21 days throughout the individual's duration. Actually, up to 24 days, I take that back. For post-exposure prophylaxis for immune globulin can be administered within 6 days of exposure. And as Dr. Seward stated, there was a change from the ACIP recommendation, and that for IgIM, it's 0.5 mLs per kilogram, and for IgIV, intravenous immune globulin, is 400 milligrams per kilogram. So got to make sure that, and normally when we're trying to get IG out, we have to reiterate this and make sure that people are very clear on the dosing and that it's 0.5, and hopefully with the new updated Red Book and other documents that we utilize for references, it will reflect this current updated change. Also, it's recommended for the following risk groups: risk of individuals that are at risk for severe disease and complications. So infants that are aged less than 12 months of age, giving them IgIM. For pregnant women without evidence of immunity, IgIV. And we usually consult with their physician to make sure that the individual is attended to and are given appropriate immune globulins so that they can be protected. And then also for those individuals that are severely immunocompromised, IgIV, and again, communicating with their physician to make sure that these individuals, the physicians are aware of what's going on and are part of their care. So as Dr. Seward again mentioned, why are we seeing measles and why is it that it's currently going on? Measles, again, is due to a failure to vaccinate. A lot of individuals are not getting vaccinated, and that's who we're seeing coming down with the disease. Here in Hawaii, from our experience in 2010 and in 2014, majority of the individuals were unvaccinated, and so the disease has been spread from or acquired by unvaccinated individuals and spread to other unvaccinated individuals, and also individuals that may not have had a full protection from the vaccine. Measles definitely is, or measles elimination is a global problem. We're seeing measles throughout the rest of the world, and it's definitely a threat for importations. As we noted in our cases here in Hawaii, Philippines was a big contributor, and also Bali for us here. But elsewhere in the U.S., we're getting importations from other parts of the world. Measles occurs in the U.S., and just because it's been eliminated, it does not mean that it's eradicated or it's gone forever. We still have the potential of coming in and acquiring the disease and spreading it further. And as was shown within the Amish community, individuals were actually who were not vaccinated. It spread really quickly throughout that community. But then you started seeing a lot of individuals that were being vaccinated after the outbreak occurred. So just try to stem the tide of the spread of the disease to further people within their community. And so another important thing, and something that I mentioned earlier, is the maintenance of elimination is resource intensive. Trying to maintain high vaccine coverage, we really need your help in ensuring that the patients and your population that you provide services to are vaccinated, and that they're vaccinated on time and they're vaccinated appropriately, spaced appropriately, and given and making sure that they have their 2 doses of MMR vaccine. As I mentioned earlier, it's an intensive investigation for us to try to contact, identify all the cases that have been exposed, trying to get their accurate phone number. Sometimes language is a barrier for us, even just trying to catch individuals that may not have phones, but we have to go out to their residence to get to communicate with them and determine if they've been vaccinated or not, and to try to monitor them to ensure that they do not come down with disease, and if they do, to provide them enough information on what the disease looks like, and if they do come down with it, to try to minimize the spread to other individuals, especially if they go into a clinic setting or an emergency room or hospital. The other thing, too, is that healthcare workers' diagnostic skills, we have to try to upkeep that because, again, a lot of our healthcare workers don't see measles often, and trying to identify what measles looks like, but also trying to make sure that they're fully vaccinated is really, really important. As I mentioned earlier, trying to have all of your staff's vaccination status readily available, because that will be one of the first questions we will ask you in doing our investigations. Who was there, who's working that were, part of your staff, and have they been vaccinated or not, and collect that information. And then also advanced laboratory techniques. Because we do live so far away from the continental U.S., especially for IgM testing, and knowing that it takes a few days for that to come back, it's really hard. But we do have the PCR testing, but we have to make sure that everything is complete with the symptoms and the signs of measles, and that the appropriate specimens are collected, and ensuring that we utilize these advances. But again, like everything else, there's definitely a cost to these laboratory techniques and advances that are currently being utilized. And so the department, we have and I believe we've handed this out and sent this out, but if you need more, we have these handouts that you can post up. They're laminated, poster size, or I guess not poster size, but 8.5 by 11 size things that you can hang up in your offices. So the first one is fever and rash. Think measles or consider measles, and it lists down again if what the prodrome looks like, about rash onset, and who to contact immediately. So you can paste this and stick this up on your wall so that information is readily available. You can contact the Department of Health, and we can provide this and send this out to you, your clinics. Also, if you have people that come in and they're saying that they're going to be traveling to another country, think measles. This actual it's really important, again, to before you travel and after you travel. So before individuals travel, you want to try to make sure that individuals are vaccinated appropriately. And if they come to you and visit and they tell you that they've traveled, you need to also do the workup to find out if they've been exposed or not exposed. So it's really important to try to put this out in your waiting areas. It's colorful, it's attractive, and again, we want to try to minimize the spread of this particular disease. Another kind of poster that was sent out, I believe, to almost all of your provider offices was a differential diagnosis guide from Merck that shows measles, mumps, rubella, varicella, et cetera. And so we sent that out to all of the pediatric offices and also to the emergency rooms throughout the state. But if you're needing any of these posters, please contact the Department of Health Immunization Branch, and we'll try. We have a few available, but whatever we have, we will definitely try to get that out to you as resources for you to utilize in your offices. And again, this is basically a plea more for the immunization registry, because if you haven't heard about our immunization registry, we want to make sure your patients and your staff are vaccinated appropriately, and vaccinations are documented in the registry. We want to make sure that all of that information is in there and that can be readily retrievable, and that it's there at your fingertips. So we want to make sure that that's documented. Here are a list of other links, and this is mirroring a little bit of what was presented from the slides from Dr. Seward. But then on the very bottom is the Hawaii Department of Health website. So you can also look into our website and find information if you're needing to look for information. Here's contact information. Normally, during work hours from Monday to Friday, that's 7:45 to 4:30, you can contact our Officer of the Day line for the immunization branch, and that number is listed there. But then after hours and on weekends, there's a number that you would need to call and contact, and there's an individual that will be able to respond to that line, and they're able to then try to provide guidance and then either contact us in the immunization branch to call you up and do more further questions and figuring out what's going on and assist you in trying to determine if it is measles or not. So again, I want to thank my staff for putting this together and getting everybody signed up for this. And so I'm just going to go ahead and hand it over to Gail so she can go ahead and do the next portion would be for questions. And I'm going to be available, Dr. Marcy Nagao will be available, and other staff that are able to hopefully answer your questions. And so Gail, can you go ahead and take over?
Sure. Thank you, Ron. Okay, so to ask a question, please type your question into the WebEx chat box. It should be at the bottom of your navigation bar, or if you're using the full screen, it should be at the top of your screen using the floating toolbar. Okay, here's a question. It says, do we need to vaccinate infants 6 to 11 months if they are traveling to California or other states that have been affected, or is this not necessary? Okay, I'm going to shoot that question over to Dr. Nagao. Did you hear that question, or shall I repeat it?
No, I heard the question. The CDC recommends that if you're traveling internationally, that 6 to 11-month-olds should be vaccinated. They don't make any recommendations for traveling within the United States.
Okay, great. Are there any other questions? You can go ahead and type it into the chat box. Okay, so then this concludes the question and answer session. An email with the link to the evaluation survey for this webinar will be sent to you. Please take the time to complete this survey as your feedback assists us in developing future educational opportunities. This concludes our presentation. Thank you for participating in today's webinar and for the work that you do to protect the health of Hawaii's keiki and our communities.